Hey listeners, welcome back to another episode of Hybrid Healing Hour. Today we're going to be discussing lower extremity vein disorders, and we have a special guest with us, Dr. Daniel Lebowitz. So will you please tell our audience a little bit about yourself and how you got to where you are today?
Sure. First of all, hi, thanks for having me. I appreciate this opportunity to have this conversation with you guys and get the information out. About myself, I'm an MD. Went to University of Michigan for college, Boston University for med school, decided to train in radiology and eventually interventional radiology. Interventional radiology, of course, means learning minimally invasive image-guided procedures. And of course, that's exactly what we do in a vein practice. So eventually ended up practicing with veins, and here we are now.
Wonderful. And I want to just dive right in. I mean, there's so much to talk about. I feel there's many different disorders of the legs. And let's start with varicose veins. So what can you tell us? How do you describe to a patient what a varicose vein is?
Sure. So veins have one job primarily, and that's to get blood back up to the heart. So as you know, arteries bring oxygenated blood down to all parts of the body, including the legs. Oxygen gets dropped off, and then we're on the vein side, and the vein's job is to get the blood back up. When people have varicose veins, or also known as chronic venous insufficiency, it means that some of the veins in their legs aren't getting the blood back up, and worse than that, the ones that aren't doing the job properly are attached to the good ones, so they're sabotaging those good veins from getting the blood out of the legs. So we have a bit of an issue.
And what are some causes of this? What happens, and why does it happen?
The pathophysiology actually is that inside your veins you have valves, and those valves help you fight gravity because those valves open up and let the blood move up towards the heart when it's trying to, and when it's trying to fall down back towards the legs, they're supposed to close and stop that from happening. In a lot of people, as they get older, the valves inside some of their veins break down, and so blood doesn't move effectively up out of the legs. And since it's easier for the blood to fall down with gravity than it is to fight its way up in the good veins, if there's an escape route, it will fall down and get stuck in the legs.
So the veins don't have muscles like arteries do. I always kind of give an example of when you're watching scary movies, and if somebody gets sliced in the neck and the blood is squirting out, they've cut an artery.
That's an artery, yeah.
If it's oozing out, they've probably cut a vein.
Yes, that's true.
And are varicose veins genetic? Is there a genetic predisposition?
Absolutely. It does run in families. It's sort of multifactorial. There's people who are prone to it and people who are not. And then like many things that are multifactorial, other things bring it out, right? So if you're on your feet a lot, that's going to bring it out. If you're overweight, that's going to accelerate the development of this problem. Multiple pregnancies, prolonged standing, sitting, things like that.
So exercise, is that a good treatment? Is that enough?
So moderate exercise is one of the things you can do to help slow the progression of this problem because squeezing the muscles helps get some of that blood out that otherwise might get trapped in the leg. So that's a pretty good thing to do. Other things you can do are wearing compression stockings because those help counteract the effects of gravity. So when you're on the feet a lot, whether sitting or standing, if your feet are below your heart, you're fighting gravity, and stockings help you fight gravity more effectively without those veins breaking down as much.
And when you say it can happen in pregnant females, is that because of the weight, or is there any other reason?
Sure. I mean, anything basically that increases pressure inside the abdomen, that increased pressure is going to transmit down to the legs and increase the problems in the development of this disorder.
Do most people have pain with varicose veins, or can they be painless?
Most people eventually experience pain. It's usually pretty early symptom, whether it's pain, cramping, aching, heaviness, tiredness of the legs, but it's usually a pretty early symptom. Not in everyone, though. Some people come in and they say, look, I've got some bulging veins here I want to show you. They don't really hurt me that much, but wanted you to take a look at these and see what we can do about it.
And because most people think that varicose veins are, especially if they don't have them, they think they're just cosmetic, right? And that there's no downside. But there are several downsides to having varicose veins that are not just cosmetic.
Yeah, exactly. So first of all, it does become symptomatic. You go through usually a progression of things. Not everyone follows the same progression, but in order of increasing severity, the first things people might notice are spider veins or varicose veins. Then they might start to notice swelling in their legs. Then they might start to notice various types of discoloration, whether it's reddish hues, purplish hues, brownish hues. Some of that becomes permanent if you let it go too long. then they can start to get actual skin problems, skin breakdown, chronic skin changes, skin ulcers, cellulitis, and eventually they're running the risk for deep vein thrombosis or a dangerous blood clot in the deep veins.
Wow. And edema is, I'm assuming, can start to accumulate as well, leading to this rash, like a venous stasis.
Absolutely.
Type of thing.
Rashes are another presenting symptom. That's true.
Okay. And so you mentioned deep veins. So before we go into the deep vein, what about those superficial venous thrombosis? Like what causes those? I think a lot of people hear about DVTs, but they don't hear about the SVT in relation to this.
Yep. So again, when you have this problem with the varicose veins, right, the blood's not effectively moving out of your leg, so it's kind of just sitting there. And anytime we have blood just sitting somewhere, not moving, it's more prone to clotting. Hopefully that's going to only be happening in someone's superficial veins, right, which leads to superficial vein thrombosis or a clot of a superficial vein, which can be very painful but not very dangerous usually. On the other hand, it can progress from happening in the superficial veins to the deep veins, and now somebody has developed deep vein thrombosis, and that's very dangerous because those clots can spread up towards the lungs and eventually put you at risk for pulmonary embolism.
And can you talk about phlebitis? That's something that we don't really talk much about. We don't even see it as much as we used to.
Sure. I mean, so someone can spontaneously get superficial vein thrombosis and get sort of like a phlebitis picture around that, which is pain, redness, irritation, maybe some swelling around the vein. It can be quite painful because you have a lot of nerve endings in the skin. So when you have a very superficial vein that's acting up like that, it can be very painful. But we also can get a post-procedure phlebitis, which can be a normal healing response and inflammation response to the procedures that we do.
I know I've seen it like a phlebitis from like IVs or drawing blood sometimes too, for people who have to get repeatedly stuck, depending on their situation.
Yep. And then you have to tease apart, well, is this just inflammation or is this infection? Mm-hmm. So, of course, we have ways of looking at that. Obviously, if there's pus coming out, we're a lot more worried about infection. If somebody has a fever, we're a lot worried about infection. But if they're just having a lot of irritation, maybe pain and itching, and it's post-procedure, that's probably more likely to just be a normal post-procedure phlebitis. And then we're just going to treat that with supportive things like Advil and compression stockings and so forth.
Does applying ice or heat make a difference?
Absolutely. So they're not the mainstays, right? So what I tell people to do post-procedure, first of all, is the stockings, the Advil, and just sort of moderate activity level. Like we said, moderate activity is good for veins. But definitely people can try hot compresses or ice, elevating the legs, right, to get the swelling down is always a good plan too, things like that.
Is that the same treatment for superficial vein thrombosis or clot?
Yeah, I would recommend all those same things, definitely.
I know a lot of people wonder if they need to go on anticoagulants or blood thinners with superficial vein clots, but that's not necessarily recommended. It's only for the deep veins. Is that correct?
Correct, yeah. So deep vein thrombosis, of course, is dangerous for the reasons we talked about before, the potential for that clot to spread up towards the lungs. So you have that danger, and that's typically considered more dangerous than the risks that you can have from taking a blood thinning medication to help break up the clot. But in the case of superficial vein thrombosis, as we said before, they're not very dangerous. They don't have much potential for spreading into the deep system and towards your lungs. So in that case, you really just want to do supportive things and kind of get through that painful period and encourage it to go away faster, but nothing so extreme as a blood thinner because those have their own risks.
And we're focusing on the lower extremity because is this not the most common area of getting clots?
It is the most common area to get clots, and also it's the most affected area by this process of the veins breaking down from gravity because the blood has the farthest, the longest fight to get back up to the heart. So
let's talk about treatment, which is where you come in, right? So what's typically your treatment for varicose veins?
Yep. So first of all, we evaluate someone and make sure we think they have this problem. And then we would get an ultrasound where we look at all the veins of both legs in detail. And on that ultrasound, we really want to look at two things. Number one, we want to prove that their deep veins are doing well because we don't necessarily want to treat someone for superficial vein problems, which is, by the way, where varicose veins, venous insufficiency happens is in the superficial veins. We don't necessarily want to treat that if they don't have good outflow in the powerful deep veins. But most everyone does, or otherwise they'd be coming to us with a DVT. So We check that. We check the deep veins first, and then we check which superficial veins are still flowing blood the correct direction and which ones seem to be breaking down and having this problem. That allows us to map out our treatment strategy and then also get insurance to cover the treatments. And the treatments themselves depend on the size of the vein, depending on the insurance. They vary somewhat, but usually for larger veins, we use a heat-based treatment called radiofrequency ablation or cyanoacrylate glue ablation for larger veins, and then for smaller veins, we use sclerotherapy, which is a foam sclerosant that we inject into the veins to close them down. So the goal is to close down just those bad superficial veins that are flowing the wrong direction. In so doing, we stop the sabotage of the blood that's happening, and then the blood can get out of the legs more effectively. Someone's symptoms get better in the short to medium term, and in the medium to long term, we're preventing all the progression complications of this that we already talked about.
In the old days, they used to do vein stripping, and that's not commonly done anymore, correct?
Yeah, that is not the direction we go anymore. That's pretty invasive. It's surgical. It leaves scars. It's causing a lot of downtime, a lot of discomfort, a lot of unnecessary risk. I believe a lot of times they put people to sleep for it because it's quite painful. None of those things are necessary anymore. So all the procedures we do are minimally invasive. They involve no anesthesia, no cutting with the scalpel whatsoever, and they don't cause any downtime, actually. So people come in, they have a quick 10 or 15-minute needle-based procedure, and then they're back to their normal daily activities. They have a few inconveniences, right? They're wearing a stocking afterwards to help get a good result. They're taking some Advil for several days to control post-procedure pain, swelling, and inflammation. But basically, they're doing all their normal moderate activity stuff.
Wow, impressive. And so what about the different types you mentioned? Can you go into, I guess, you already said you make sure they have good flow otherwise, but do you ever see where people develop new vasculature? What is your recommendation for, I guess, how do you explain how the blood will flow when you block off the other non-effective vein?
Yeah, it's a great question. And people get a little worried when you tell them you're closing veins.
Right, I guess that's what I want to get at.
Are you stopping my blood flow? And the answer is no. We're actually improving your blood flow out of your legs. We're just preventing the blood from getting trapped in your legs. So the veins we're closing down are sabotaging the blood flow out of the patient's leg at that point in time. We don't have the technology to fix those veins, but we do know that when you close them, number one, they weren't really needed because the deep veins, as long as they're working properly, are more than strong enough to get all the blood out on their own. And then we stop the sabotage, those veins can do a better job getting the blood out.
Okay. And I know the varicose veins or venous insufficiency can look at many in different ways. Some people get cord-like or snake-like veins that are very palpable and visible, and then others not so much. Would you describe this as is one worse than the other? Is one better than the other in any way? Or easier to treat versus harder to treat?
The analogy I like to use here is the Titanic.
Okay.
Right? So you have the Titanic trying to steer clear of the iceberg, right? We see the iceberg. There it is. We're going left. We're going to miss it, right? But no, because it's 10 times as big under the surface and it rips through the side of their hull on the undersurface, and they didn't realize. If somebody has something going on that you can see on the surface of their skin, that's your key that you need to look inside and see. They probably have a lot going on farther inside, because the problem is that's happening is the blood's backing up from the big veins that are farther inside to the medium veins, to those smaller veins or even spider veins on the skin. And that's your clue. You need to look farther inside and farther upstream to where the problem's really occurring from.
That was very well put. I like that description a lot.
Thanks. I do talk about this every day.
Yes.
So.
Well, I think in a primary care setting, obviously I didn't have training on specifically the vasculature, right? But I have heard a lot in my past with other primary care physicians and providers saying, "Oh, it's just a varicose vein," and and it's like a big one, and they're like, "I'm like, does it, hurt?" And if they say no, it doesn't, it's kind of bypassed. Nobody makes time for that. But I like how you said, if that one is big on the outside, then imagine what the inside is looking like, and we probably need to fix that.
Exactly right.
Wow.
And almost always the case. Yeah.
And once someone has had a vein procedure, does that preclude them from having another one down the road if it were to develop?
Not at all. So what I always tell people is, look, the veins we're treating, when we successfully treat them, they're going away, they're not coming back. But what happens with this problem is that everyone is slowly making new veins, And when you have this underlying condition, your new veins are going to slowly start to become abnormal, just like the ones you've already had have slowly become abnormal. So we monitor people around once a year, once they've gone through a treatment program with us. And we monitor them once a year with a new ultrasound, a new visit to see how their symptoms are doing. Hopefully they're not having any. Hopefully we don't find any new veins to treat. But if we do, it's usually just a couple quick procedures, and they're good for another year or 2 or 3.
What's the downtime after the procedure?
There's really no downtime, as I alluded to before, but there's a couple minor restrictions. So after needle sticks, we don't want to get the skin infected. So 24 hours, you're not going to swim or get it wet. First 48 hours, I don't want people lifting anything too heavy because you might pop back open that vein we just worked so hard to close, and then it's a redo. And first 48 hours, I don't want people traveling because, again, that's immobilizing the leg, making them more prone to that complication of blood clot. And we don't want that. We want people moving after these. But other than that, all the normal activities right after the procedure are fair game, even jogging, playing golf, tennis, stuff like that.
Okay.
Does hydration have a key in this?
I can't point to any scientific literature, right, to say that hydration plays a direct role in this. But what I can tell you is that one of the many presenting symptoms that people get with this is nighttime cramping, right? And typically when we do treat their varicose vein problems, their venous insufficiency, their nighttime cramping greatly improves or goes away. However, there's other things that contribute to nighttime cramping. Electrolyte imbalances, dehydration, possibly indirectly thyroid problems with making people more prone to cold temperatures. Some people say their cramps are set off by cold temperatures. So all sorts of things like that.
Right. Well, I have some other questions. So what about traveling? After a procedure, how soon could somebody travel? Like fly or drive? What's your guideline on that?
Yep. So I don't really want someone traveling any significant length of time within the first 48 hours. After 48 hours, I'd put them pretty much in the same risk category as someone who didn't just have a procedure. But before 48 hours, I want them to be very careful with that. Now, any vein patient, when they're traveling, I want them to be wearing compression stockings the whole time. And I want them to be getting up every hour or so and walking around for a couple of minutes, even if it's annoying everyone else on the plane, because that's how you keep your veins safe from blood clots.
Can you talk about compression stockings for a little bit? Like, do you measure them? Do you recommend a certain millimeter of mercury? Do you recommend closed toe, open toe, knee high, thigh high?
So I'll be honest, my staff handles this in my office. So they're probably more up on the details, the little gritty details than I am. But yes, we do recommend a certain amount of compression, 20 to 30 milligrams of mercury. Is the standard what we want for medical. That's enough for veins and not so much that it's going to cause any problems with the arteries. You do want that good level of compression. I prefer a stocking that goes all the way down to the toes if someone can tolerate it, because what you find with ones that stop at the ankle or the midfoot is a lot of people will come back and tell you, well, my leg's not swollen anymore, but now the part of my foot that sticks out is. Mm-hmm. So you don't want that.
I had somebody the other day, their toes were like purple, and I'm like, is this too tight? But it wasn't too tight. It was just like, their toes were discolored. I'm like, we probably need to cover those.
Yeah.
Yeah. Okay, thank you. And can you talk about venous insufficiency? What about when people, we have, living here in Southeast Florida, a lot of people go to Disney World for like a weekend, and they come back, and even if they're young and healthy, they're like, my ankles are swollen, and or I'm red down there. I have a rash. What is this?
Yeah, so that's probably mainly a function of spending much more time on their feet, standing in line for all the attractions and so forth than they're used to. And so when you have this problem, right, the longer you spend fighting gravity and you've progressed to that point, your legs are going to start to swell if you have enough vein problems going on in your legs. So when someone's going to Disney World or doing a lot of traveling and their feet are spending a long time kind of immobilized without muscular contractions, or standing in line immobilized without muscular contractions, but also fighting gravity, that's when the swelling is going to be at its worst. That's why a lot of people who come to me say, yeah, I have swelling sometimes, but mostly just when I travel or when I stand for a long time. Those are people who are progressing down that road towards getting more and more swelling symptoms, but so far it's only happening under certain circumstances.
What do you feel about those shoes? Like Skechers has the rockers, or shoes that keep people maybe from, or helps them move while they're standing still. Have you Any feedback on that?
I wouldn't say I'm an expert on that particular topic, but what I would say is the more people can move when they're supposed to be sitting still or standing still without getting into trouble with their job or their school or what have you, the better, right? Because again, those muscular contractions help get the blood up.
At least do some calf raises while standing in line.
Exactly. Or while sitting.
Or while sitting, exactly. Pump your
raises.
legs, write your name with the alphabet with your foot.
You got it.
And so are spider veins considered venous insufficiency as well?
Good question. It's a related diagnosis, but not exactly the same. In other words, when we treat what's going on, let's say inside, what we find on the ultrasound, we're treating the ones that are covered by insurance that are considered a medical problem, right? But again, as I said earlier, this is a problem that's happening because the big veins are backflowing. They're backflowing into the medium, then the small, then the tiny surface veins, and then the spider veins. So it is all the same pathophysiology, but many times when we fix what's going on inside, it still doesn't resolve people's spider veins. They have to specifically go and get those treated. But it's worth mentioning that if they don't fix the medical problems inside and just are constantly going for spider vein treatments, that's the key word, is constantly. They'll be having to do it over and over and over again because they never really fixed the medical problem inside that's causing all of this, and the spider veins are just going to keep coming back.
So there's a lot of like spas out there, I think, that claim that they treat the spider veins. And so I like your piece of advice there. That might not be the end-all solution.
Yep. The best thing overall for the patient is to treat the medical problems that are going on, stop that progression. And then if they want to go to treat the spider veins, they're going to stay away much, much longer. It's going to save the patient a lot of money and a lot of unnecessary needles.
Wow. So spider veins are not just a cosmetic thing either. Not necessarily.
Well, the spider veins themselves are pretty much cosmetic, but they're a symptom of the underlying medical problem.
Okay.
That almost everybody who has a lot of spider veins is going to have too.
So again, ultrasound is probably the best way to work that up.
Yeah, come see us. We'll look into what's going on.
And do you have any recommendations for people with genetic predispositions for clots, like factor V Leiden or factor II prothrombin mutation? Anything, I guess that's going back to like a DVT question.
Yeah, hematologists, I would defer to them on their expertise as to exactly who should be prophylactically on blood thinners and exactly what precautions they should take. I will say this. Often we see people for rule out DVT, right? And typically they've had some sort of episode of pain and swelling in their leg. I would say 90+% of the time when someone's coming in with that spontaneous set of symptoms and complaints and findings, they don't have DVT. But I would say 99% of those, in my experience, do have chronic venous insufficiency that's leading to these kind of pseudo DVT episodes that the person's experiencing, and they're going to keep happening, and that's kind of like their red flag, their warning sign that, hey, time to treat your vein disease, it's getting bad.
Have you found, I know, like you said, you kind of refer to the hematologist for questions like this maybe, but like birth control, hormone replacement therapy, are those things that you ever advise on?
Well, definitely it's known that birth control, especially over age 35, is putting people at increased risk of blood clots of all sorts, DVT, pulmonary emboli, and so forth. So definitely going to be worrying about that if somebody comes in, rule out DVT, and they tell me, hey, I'm 38 and I just started a birth control pill. Yeah, that would make me worried. Similarly, some of the hormone replacements, if you're not careful, can increase the risk of blood clots. I'm not necessarily up on the details at this moment, but that's definitely true that can be a risk factor as well.
And I know we tell our patients, because we do screen for genetic issues, and so when we find that, we tell them whether you've had a clot or not, you got to get up, you got to walk, you can't be sitting in one place for long, especially when you travel, when you're flying, just like you do with your post-procedure patients.
And we also try not to put them on birth control if they have something like that as well.
Exactly. It's a good idea for young females to know some of those genetics before they go on long-term birth control.
Can you explain the difference between a provoked and an unprovoked DVT?
Yeah, from a treatment perspective, it may or may not make a difference, but I guess you could say provoked would be if you could point to an episode where somebody, let's say, took a long flight and then they got off the plane and said, man, my calf really hurts and it's starting to swell. We could call that a provoked DVT. And we could say somebody who's just going through normal life and one day notices the same symptoms, pain and swelling, you could call that unprovoked. Right. So it may or may not have anything to do with what kind of underlying risk factors they have. But, you know, in the first place, you want to diagnose them properly. Mm-hmm. And then for in my opinion, you should always do a workup and make sure there's no underlying clotting disorder, no matter whether it's provoked or unprovoked, and then, you know, go from there.
Right. Yeah, we usually, I actually just had a patient recently, and I sent to you guys first, and then we both referred straight to hematology for further workup because it wasn't a clear-cut situation.
Yeah.
Yep. And so can we go ahead and just talk about some treatments for DVT? What do you do immediately in your office if somebody, you say they're scanning, just making sure, and if they are diagnosed with a DVT, what do you start them on?
Well, so first of all, I would differentiate between someone who comes in as rule-out DVT to our office and someone who may have, as a complication of a procedure, rarely get a DVT or something along the lines of a DVT from our procedures. Someone who comes in as a rule-out DVT, it really depends on what their situation is. Do they have a known history of DVT? Do they have a known clotting disorder? Have they ever been treated for DVT before? How did that treatment work? So you look into all those sorts of things. But the most common situation, if someone has a DVT that's in a important enough vein, we make a little bit of a distinction between above the knee and below the knee. Below the knee DVTs are less concerning, but they're less likely to propagate up and become those pulmonary emboli. And then you also think about how symptomatic they are, how does the clot look like, and so forth, and you make a decision whether or not to put them on a blood thinner. Many cases you will put somebody on a blood thinner, and if it's, you know, either unprovoked or we don't know why they have it, then it's probably going to be the case that we put them on a blood thinner for at least several months, at least 6 months, to sort of stabilize that clot and make sure it's not going to propagate. If you're less worried about that, you might be able to and they're not that symptomatic, then you might be able to get away with just carefully watching it, wearing compression stockings, and, you know, keeping a very close eye on things and see how they do. If it's from our patients post-procedure, depending on what we think is going on, is it from one of our glue procedures and it's actually just a little bit of glue went a little deeper into the vein than we want to, that's not as concerning as if it's actual blood clot, right? Because glue doesn't have that propensity to propagate like an actual clot does. So in that case, we're even less likely to treat with any blood thinners. But again, we're looking at things like how bad does it look on ultrasound, how symptomatic are they, to help us make that decision.
Very good. And do you guys have anything like nowadays with like filler in the face? They have things that can dissolve. Like, do you have anything like that with the glue that you use? Or are there any dissolvable?
No, we don't use anything like that.
Okay.
I know that once upon a time, for people with recurrent DVTs, IVC filters used to be commonly used. We don't see them much anymore. Right? I don't think that. I think they've gone out of favor because of the newer anticoagulants we have.
Yeah, between that and there's also, you know, thrombolysis that can be done if necessary. So it's not as common, but they're definitely still putting some in.
If someone has a DVT, are they able to exercise still, or do you recommend to refrain from exercise?
I think it depends, again, on the particulars of the situation. Okay. If it's fresh and we're worried about it propagating or breaking off and it looks like it might be prone to do something like that, then definitely they shouldn't be exercising. On the other hand, if you've had somebody who's been 6 months already on a blood thinner and you can still see that they have blood clot, but it's, you know, considered stabilized by that point, that's safe for that person to exercise.
Okay.
So and really, it's not black and white. It's kind of a gray zone, yeah.
And what about the traveling for them, too? Because I kind of have been asked this question, well, if I'm already on the blood thinners, can't I travel?
So, again, how stable does their clot seem? What's the risk we think of it propagating? Is it in a concerning location or a less concerning location? All those same things apply. And
does the size of the clot matter? Like, because I've seen some that are quite large and then some that are small.
Sure, right. So the size matters, the location matters, how much of the lumen of the blood vessel or the center part where it's supposed to be flowing blood is occluded. Is it occlusive or non-occlusive of the whole blood vessel? All those things play into that.
Which can all be determined just by simple ultrasound.
Yes, or other imaging modalities.
Okay.
Like MR venography and CT venography if necessary. But usually ultrasound is the mainstay.
Are there any other venous conditions that you treat other than the ones we've talked about?
In my office, we do very much so venous insufficiency. It's very common, troubles people a lot, and we are very good at helping people with that. We do obviously a fair bit of treating DVT patients, diagnosing and treating DVT patients. That's pretty much 99.9% of what we're seeing and doing.
Okay.
Well, it's good to have a specialist like you guys in the area. So thank you, Dr. Lebowitz, for coming on. This was great and very informative.
Yeah, thank you. I appreciate the opportunity.
Can you tell our audience how they can reach you and come see you?
Sure. So the practice I work for is United Vein and Vascular. The website is unitedveincenters.com. Our local phone number is 561-770-3370. But just so people know, that will get them to a call center, not directly to our office, and then their call will be routed appropriately. We're at 1900 Glades Road in Boca Raton, Suite 100.
Perfect.
Right.
I'll put all that in the show notes too.
Appreciate it, guys. Thanks a lot.
Thank you.
Have a good day.
The information contained in this podcast is provided for informational and educational purposes only and is not intended for the purposes of diagnosing, curing, treating, or preventing any disease. This podcast is provided on the understanding that it does not constitute medical or other professional advice or services. Before using any products or services referenced on this podcast, consult with your healthcare provider, carefully read all labels, and heed all directions and cautions that accompany the products. Information found or received through the podcast should not be used in place of a consultation or advice from a healthcare provider. If you suspect you have a medical problem or should you have any healthcare questions, please promptly call or see your healthcare provider. This podcast, including Dr. Brian Marias, Deanna Weilbacher, and Hybrid Medical Solution, do not claim responsibility for any adverse effects from the use of information contained herein. Opinions of guests are their own, and this podcast does not endorse or accept responsibility for any statements made by the guests. This podcast does not make any representations or warranties about guest qualifications or credibility. This podcast may contain paid endorsements and advertisements for products or services. Individuals on this podcast may have a direct or indirect financial interest in products or services referenced.
If you would like to submit any questions or if you have any topics you would be interested in hearing about on future episodes, please contact us through our website, www.hybridmedicalsolution.com. That is solution with no S at the end. Follow us on Instagram and Facebook, all under Hybrid Medical Solution.